Okay, we have two presenters joining us here this morning. Mary Kashak is Executive Director of LTQA. She also serves as Executive Director of LTQA's affiliated organization, the National MLTSS Health Plan Association. Prior to joining LTQA and the association, she spent 10 years at the National Association of Area Agencies on Aging, most recently as Deputy Director of the Aging and Disability Business Institute. Tyler Overstreet-Cromer is Senior Vice President at Ann Tumlinson Innovations, where she advises clients on innovative financing and service delivery models. Previously, she served as a Senior Executive at the Office of Management and Budget, providing oversight and expertise for budget development and execution across the Department of Health and Human Services. And at this point, I would like to turn the floor over to our presenters here this morning, Mary and Tyler. Welcome.
Hi, good morning. This is Tyler Cromer speaking here first, and I'm just going to move us on through some slides to get us going. First, just a little bit about ATI Advisory. We are a research and advisory services firm here in Washington, D.C., and we are fully focused on changing how businesses, communities, and public programs serve frail older adults. And we do that by partnering with our clients to come up with really what we believe are great solutions for this population of folks where we focus our work and our energy. So just a little bit about ATI Advisory here on this first slide, and then I'm going to turn it over to Mary to tell you just a little bit of LTQA, a little bit about LTQA before we dive into the content.
Great, thanks Tyler, and thank you to Steve, ASA, and Foreign the Business Institute for hosting this webinar this afternoon. So LTQA is a 501c3 membership organization based here in Washington, D.C. And LTQA's mission is to advance the availability, affordability, and access to high-quality person and family-centered coordinated long-term services and supports through building the evidence base, engaging and educating public and private sector stakeholders, convening stakeholders around innovative models that achieve better outcomes, reduce expenditures, and provide a platform for financing LTSS. And we're really excited to have the opportunity to partner with ATI Advisory on this great work around advancing non-traditional benefits in Medicare Advantage. And so with that, I'll turn it back over to Tyler to dive into the content.
Great. So just to give you all a sense of our roadmap for today, we're going to start by talking about the policy changes that allow for these new benefits to be offered in Medicare Advantage. Then we're going to tell you a little bit about the work that LTQA and ATI Advisory did in collaboration and with support from the SCAN Foundation to develop some guiding principles about how to implement these new benefits in Medicare. Then we're going to go through what we're seeing in the data. So what are these new supplemental non-medical benefits? What are they? Who's offering them and where are they offering them? We're going to spend a good part of our time today going over that. And then we're going to talk about some of the trends and challenges that we're seeing and have time for discussion and answering your questions at the end of the call. So that's our roadmap for the day. And here we go. Starting off, a turning point in Medicare policy. So why do older adults choose Medicare Advantage? Why would they choose to go into these private insurance plans offered by private companies over the traditional Medicare fee-for-service program? The short answer is to save money. Original fee-for-service has some high deductibles, some high coinsurance amounts, and Medicare Advantage really limits some of that financial risk for adults who are eligible for Medicare. So they join to save money, and they join to get benefits that traditional Medicare does not cover. So many of you are probably very familiar with what Medicare does and doesn't cover, but some of you may not be. And some of you may be surprised to know that Medicare doesn't cover things like dental and vision and hearing. And a lot of our Medicare Advantage plans do cover these benefits, and that can be very attractive to individuals. So that's what you see in that blue box. And then if you look down to the green box, this is what we're talking about today, which are these new non-medical benefits that plans are able to offer, some of which they were able to offer starting in plan year 2019, many of which they weren't able to offer until this plan year 2020. And this slide, slide 8, tells you a little bit about some of the demographic information about Medicare beneficiaries who are served by Medicare Advantage. So what I want to highlight for you here is that a higher proportion of individuals enrolled in Medicare Advantage are living in that under 200% of federal poverty level. So, you know, if you look at the bar on the left, you're going to see, you know, in this green section, a much higher percentage, 28% of Medicare Advantage enrollees are living at 100 to 199% of FPL. That's going to be about $2,000 a month for an individual, 200% of the federal poverty level. Whereas if you look on the bar chart on the right, only about 20% of Medicare fee-for-service beneficiaries are living at that income level. And then, you know, sort of the converse of that, you can see, again, on the bar chart on the right, a higher proportion of fee-for-service beneficiaries have income over 400% of the federal poverty level. You can see that 34% in the light blue at the top versus about 25% in Medicare Advantage. So, you know, really we are looking at a Medicare Advantage population that is more likely to live below 200% of FPL. And a little bit more information about the Medicare Advantage population here. They are just as likely as fee-for-service beneficiaries to have chronic conditions. So this is just, you know, a sampling of conditions, you know, chronic heart failure, COPD, diabetes, and dementia or Alzheimer's. And you can see in blue the Medicare Advantage levels of these diseases, and in green fee-for-service. And you can see that they're pretty similar in their makeup as it relates to these conditions. And we're also seeing similar levels of functional need. So in our analysis of the Medicare Current Beneficiary Survey, you can see that, that people are just about as likely, whether they're in Medicare Advantage or traditional fee-for-service Medicare, to need help with one or more instrumental activities of daily living. These are things like paying bills, doing the grocery shopping. They are also similarly likely to need help with activities of daily living. You know, these are things like bathing, getting dressed, ambulating. And so we are seeing similar levels of both chronic conditions and functional decline across the two populations. And why do we care about that? Chronic conditions are very closely associated with higher healthcare spending, as you can see in this chart and in this analysis, where if you have 3 or more chronic conditions, you cost more than double what an individual who has 0 to 2 chronic conditions cost. But you know, even sort of more strongly associated, you can see the impact of functional impairment on healthcare spending. If you have functional impairment along with those chronic conditions, you're likely to cost a lot more healthcare dollars. And so, you know, we really believe that benefit flexibility is necessary to manage this complex care population moving forward. So, you know, status quo is volume-based care, paying per service. The more services you provide, the more widgets you provide, the more procedures you provide, the more you are paid. That is how our system has worked for many years. At many levels, federal, state, local, at many, many levels, we're working to redeploy those dollars in a way that is more person-focused, that focuses on integrated primary care, meeting the person where they are to reduce ER and inpatient visits, to deliver, on the far right here, better value to consumers, right? So better clinical outcomes, services that allow them to stay in their homes longer, which is where most people want to be, and that really allow them to have longer lives and services that meet them where they are. So with that, I'm going to turn it back to Mary to talk a little bit about how CMS has recognized the need for these newer services in Medicare.
Great, thank you so much, Tyler. So in this current calendar year of 2020, there are really two main pathways that are available to Medicare Advantage plans to offer non-medical supplemental benefits to their members. And these fall into two categories: primarily health-related supplemental benefits and special supplemental benefits for the chronically ill, or as we use the acronym because we're here in DC and everything has an acronym, SSBCI. So first I'm going to start with just going a brief overview of the primarily health-related supplemental benefits that were actually available to Medicare Advantage plans to utilize in calendar year 2019, and so this year 2020 is the second year that Medicare Advantage plans have additional flexibility based on an expanded definition of primarily health-related. So prior to calendar year 2019, all plans were required to offer the same benefit to all enrollees within their plan. That's not to say that the supplemental benefits had to be the same across different Medicare Advantage plans, but within a plan, all enrollees had to have the same access to benefits. Under the new rule that was interpreted for 2019 and beyond, Medicare Advantage plans are now allowed to target these primarily health-related supplemental benefits to groups of enrollees who have certain clinical diagnoses. And so it waives that uniformity requirement, and the only uniformity that is required now is that enrollees with the same diagnoses have access to the same type of these primarily health-related benefits. At the same time, they also expanded that definition of what is considered to be primarily health-related. So previously, the definition of primarily health-related was limited to an item or service whose primary purpose is to prevent, cure, or diminish an illness or injury. So items that were intended for daily maintenance or comfort were restricted from being offered. And in 2018, for year 2019 and beyond, CMS really expanded the scope of primarily health-related to services that could diagnose, prevent, or treat an illness or injury, compensate for physical impairment, act to ameliorate the functional psychological impact of injuries or health conditions, or reduce avoidable emergency and healthcare utilization. So with this new definition or expanded definition of primarily health-related, they do have to be provided by, or they must be recommended by a licensed professional as part of a care plan, and they cannot be cosmetic or for comfort or social determinant purposes. And that's really important, is to remember that these primarily health-related supplemental benefits cannot be primarily used to impact the social determinants of health. Some services that CMS provided as examples that could be primarily health-related are adult day services, in home-based palliative care, in-home support services, and support for caregivers of enrollees. And then in 2018, Congress had passed the Chronic Care Act as part of the Bipartisan Budgets Act of 2018, which created an entirely new supplemental benefit category in statute. In addition to the expansion of the primarily health-related supplemental benefits that I had just described, I think we're going out of order there for a second, going back to the current slide. There we go. So in addition to the primarily health-related supplemental benefits that I just described, Medicare Advantage plans, as of 2020, now have even greater flexibility to provide new sets of benefits to chronically ill enrollees called the Special Supplemental Benefits for the Chronically Ill, or SSBCI. These benefits can be specifically targeted or tailored to individual need and may include services that target the social determinants of health. So for 2020, Medicare Advantage plans are able to offer these new benefits, and they have the flexibility to develop services they offer as SSBCI as long as there is reasonable expectation of improving and or maintaining health or overall function. They can target these SSBCI as it relates to the individual enrollee's specific condition and needs to address the social determinants of health. And they can consider SDOH as one, but not the only factor in targeting these benefits. And some examples that CMS had provided of the benefits that could fall under this category of SSBCI are meals beyond the limited basis that was already available post-discharge from a hospital, food and produce, non-medical transportation, pest control, social needs benefits. And these, again, are just examples that CMS had provided that could, of the types of services that could be included under these primarily health-related, or under the special supplemental benefits for the chronically ill. And so given that there is this new change in Medicare principles, really, under the leadership of the SCAN Foundation, ATI Advisory and LTQA convened a large working group of various stakeholders to develop guiding principles for the implementation of these new flexible non-medical benefits. And this is really because this was a huge turning point in Medicare policy. There were really two main principles of Medicare policy prior to 2018, and that was benefits had to be applied uniformly for all Medicare Advantage enrollees within a plan, and that they had to be primarily health-related. And so now with both the expanded definition of primarily health-related and these new special supplemental benefits for the chronically ill, that really kind of changes two of those long-standing principles of the Medicare program. And so it was decided that there really needed to be some foundational principles that can inform regulation, development, benefit design, and form the basis of a common language for all of us who are stakeholders in this space to be effective in implementing these new benefits. And so on the next slide here, you can see the big list of entities that were really involved in the development of these principles. And so we had representatives from provider groups, from Medicare Advantage plans, from health plan associations, from some consumer and advocacy groups, from think tanks, from foundations. It was really a wide array of organizations involved in the development of these guiding principles. And here's our graphic. So at the center of these is a core principle that the SSBCI, the Special Supplemental Benefits for the Chronically Ill, really reflect individual need. And then there are 4 balancing principles, because we do recognize that there is a little bit of a tension providing something that would reflect individual need in the Medicare Advantage program, especially when these benefits do not have the funding behind them to develop them in a truly person-centered way. So there is no person-centered care planning process that happens in the development of these benefits or implementation of them, but they are intended to reflect individual need. And so that is our core principle, and is represented by these other 4 balancing principles on the outside, which I'm going to talk a little bit more about. And then on the outside of our graphic here, you can also see the word collaboration. And collaboration, although was not a principle in and of itself, it was felt very strongly by all of the members of the working group that we worked with that implementation of these new benefits in a meaningful way to have the maximum impact for Medicare Advantage enrollees would require collaboration at all levels and new levels of collaboration that hasn't been needed in the past. So that's collaboration amongst providers like community-based organizations and health plans, collaboration with Medicare Advantage enrollees and their caregivers, collaboration with CMS and other regulators to make sure that these benefits are provided in the most meaningful way possible. And so again, here are the our core principles that SSBCI reflect individual need and our 4 balancing principles. And so our first balancing principle is that SSBCI are clear and understandable. It's really important that key stakeholders, including Medicare beneficiaries and their caregivers, providers, payers, enrollment counselors, and states really understand SSBCI as well as the limitations and circumstances under which they are available. And so just because these benefits may be offered by Medicare Advantage plans, Tyler is going to talk a little bit more about this. Not all Medicare Advantage plans are currently offering these SSBCI. And even when they are offering SSBCI, it is not unlimited. So although these are LTSS-like services that you may see in traditional LTSS, the amount of funding available for these supplemental benefits is still very limited, and they are not occurring in a long-term duration as you would under a traditional LTSS benefit service. So although it might be LTSS benefits, it's not being provided in a truly comprehensive way that could meet all of the LTSS needs of Medicare Advantage enrollees. Our second principle is that SSBCI are equitable. So like all Medicare benefits, it was really important to state that SSBCI are provided in a consistent, equitable, and non-discriminatory manner that determines and meets individual need based on chronic illness and functional status. And so it was really important that these are equitable. And this does not necessarily mean, again, that plans would be offering the same types of SSBCI, but within a plan, within a calendar year, that the same benefits would be available to similarly positioned enrollees based on chronic illness and functional status and social determinants of health needs. The third balancing principle here is that SSBCI are manageable and sustainable. So this really requires that Medicare program regulations and guidance, such as rate structures and quality measures, support Medicare Advantage plans in offering, managing, and sustaining the inclusion of SSBCI. So this is a whole new world for Medicare Advantage plans, and it really stuck with me as we were kind of talking through this, is that one of the Medicare Advantage plans said, Medicare Advantage plans trying this at all initially should be considered a success. So even piloting some of these new benefits that are not common to Medicare Advantage plans can be considered a success. And there are still a number of challenges for Medicare Advantage plans in kind of figuring out how to provide these benefits and how to target them and developing the provider network. And so what we thought was really important is that these benefits are manageable and sustainable, and that hopefully we will see more and more Medicare Advantage plans providing them over time, because we do know how important they are for individuals with chronic illness and functional limitations. Our final balancing principle is that SSBCI evolve with continuous learning and improvement. And this really requires that the Department of Health and Human Services and CMS, in conjunction with MA plans and other stakeholders, are able to evaluate and measure the extent to which SSBCI are contributing towards meeting the needs of chronically ill enrollees, and that Medicare Advantage plans are able to learn from trying out these new benefits and are able to adapt and adjust based on the learnings that they have, so that we can continue to see some quality improvement and some continuous improvement year after year as we're seeing more Medicare Advantage plans start to offer these benefits. The working group had several next steps that they had recommended to us in terms of, so after these principles are in place, now what? And ATI Advisory and LTQA are actively continuing our work with the SCAN Foundation and the working group who developed the principles to meet some of these next steps. So please stay tuned and stay in touch with ATI Advisory and LTQA as we continue down this path for the next couple years. And also wanted to share some of the perspectives from the working group specifically. And this was really that calendar year 2020 is a growth year for these benefits, these non-medical, primarily health-related benefits, and a stepping stone year for SSBCI. And you'll see that reflected in the data that Tyler is going to be sharing shortly, that there are still a very limited number of plans offering both of these types of benefits, but we are seeing a little bit more offering the non-medical, primarily health-related benefits that were available for MA plans to offer in 2019. There was a big need for better beneficiary awareness over the offerings and a need for policymaker awareness on plan business challenges. So what does it really take for Medicare Advantage plans to offer these benefits? And that there were some needs going forward. So assuring these principles are being realized requires data, and there's a continuous need to build the evidence base. For those of you who have been involved in long-term services and supports, supporting the types of services that address the social determinants of health, there's still a lack of data available, and I think specifically within the Medicare Advantage space, we want to be able to build the evidence base here. Plans and providers need simple means of connecting and communicating. I think one of the main challenges that stuck with me from the working group around these new benefits is that Medicare Advantage plans aren't always sure where to form these provider networks and where to find the providers and how to gauge the quality and communicate with the providers they may be partnering with to provide these new benefits. And that consumers and stakeholders need clear information. There's a lot of confusion around what's available in Medicare already, and that is critical to make sure that beneficiaries and their caregivers really understand what's in these new benefits. So now I'm going to turn it back over to Tyler to talk a little bit more about the activity today and what plans are doing in 2020. So Tyler?
Great, thanks Mary. Thanks for that wonderful overview of the working group's work so far. Here, and I would just want to note for folks, something is happening with the page number, so everything looks like it's slide 8, so I almost just said here on slide 8, this is clearly not slide 8. But this slide, which is slide 30, is I think the one place you can go to get a quick snapshot of what is happening with SSBCI and these new primarily health-related benefits. So we have put here in one slide a count of the number of plans offering these benefits in 2020. And this is, if you look at the top half, this is the primarily health-related supplemental benefits, the benefits that were expanded in 2019. This is a subset of those benefits, but these are the 5 categories of benefits that are new in 2019. There were some expansions, but within the data, these are the 5 that we can readily pull out of the data and say that these are new benefits from that 2019 guidance. And then the second half of this slide is all of the SSBCI that are first available in 2020. So this is all, everything you see on this slide is a new offering since 2019, and the second half of it is new in 2020. So you can see that there are about 500 plans offering those primarily health-related benefits, and about 245 offering at least one SSBCI. You cannot add the black numbers to get to the red numbers because some plans are offering more than one. Just a warning about that. When you try to do it, it won't work. So what we're going to do, you'll see, and you all will have access to these slides, there is a ton of information in here, and we have limited time today. So what I'd like to do is give you a sense of what's in these slides, highlight some of the benefits, and we'll move quickly through some of them, but you'll have all of this information at your fingertips moving forward, and hopefully this will help you to know how to use it. So we're going to start with in-home support services, and you'll see in the upper left box is a definition of what is in-home support services, right? So you can see here that these are services to help people in performing ADLs and IADLs. In the box below that, we're going to tell you where are these benefits being offered. So in 30 states in Puerto Rico. So in-home support services is one of the most popular new benefits. And being one of the most popular, you can see it's still not available in all geographies. So you can see here a quick snapshot of where the benefits are available. And then we're telling you how many plans are offering this benefit. And it's 223 plans. We're also providing you that number in the parentheses without DSNPs or dually eligible special needs plans and MMPs. And the reason we provide that number for you too is because most of these benefits were able to be provided through DSNPs and MMPs prior to these policy changes. Now, if you see a DSNP or an MMP offering these benefits, that means it's being offered through the Medicare available dollars. But we're providing both those numbers for you. As we go through, you'll see some maps. The maps reflect the numbers with the DSNPs included. And then finally, we're going to tell you how many enrollees are in these plans. So you can see that over 1 million Medicare beneficiaries are enrolled in one of these 223 plans as of March of this year. I want to give you some caveats about that number. That does not tell you how many people are actually eligible for the benefit, and that does not tell you how many people are actually using the benefit. It's just the number of people enrolled in the plan. That is the best data that is available at this point. Moving along, we are here. You can see the organizations offering in-home support services, and you can see this is really a wide variety of insurers that are offering this, from the really large nationwide insurers like Aetna and United to some more regional plans are on this list. Because you see a plan's name on this list or an issuer's name on this list, that doesn't mean all their plans are offering this. It just means at least one of their plans is offering in-home support services. And then on the right side here, you're just going to see some examples. And I think what I want to highlight for you here, building on what Mary said earlier, is that these are not benefits that can take the place of other things, meaning these are really limited. So you can see from these examples, we're talking about 8 4-hour shifts or up to a maximum of 42 hours per year. So you can see this is truly a really limited benefit. This is not the type of benefit that could take the place of an ongoing long-term service and support provided either through private pay or Medicaid. So really, that's important to know. These are benefits that certainly should follow the principles, but there are limited dollars for these benefits. So want to highlight that for you there. And then the next thing you're going to see is a map that gives you a quick way to see where the benefits are being offered across the country. And so you can see, as I was saying, in-home support services is one of the more popular benefits. So you're going to see some really pretty good coverage along a good part of the East Coast and in the Midwest. Obviously, there's not coverage everywhere, but then you're going to see a lot of the western part of our country does not have, there are no offerings I will not spend that much time on all of these benefits, but wanted to give you a sense of what is in here and where you can go to read more. So, Adult Day, you're going to see the exact same information laid out the way that we just talked about on the slides that follow here. And the same thing for caregiver support. On this next slide, you can see how many plans are offering it, where, and how many Medicare beneficiaries are enrolled in these plans. You can see that caregiver support is a fairly broadly offered benefit, but not as available as widely as in-home support services. You can see the map looks quite different in the Southeast, for example, than it did for in-home support services. So the three benefits we just went over are a subset of the benefits that were available through CMS's action in 2019 to broaden that definition of what primarily health-related means. Now we're going to move in to SSBCI, or Special Supplemental Benefits for the Chronically Ill. Rolls off the tongue. These are the benefits that are totally new in 2020, available for the first time as the result of the Chronic Care Act. So we're going to start with food and produce, which is one, if not the most popular offering in SSBCI. This is what it sounds like, right? It's food and produce that's available to assist chronically ill enrollees in meeting their nutritional needs. So we're seeing right around 100 plans offering this. It's available in 23 states to almost 1 million Medicare beneficiaries. You can see the organizations that are offering food and produce. And again, the map, you can see the Midwest and Virginia, Pennsylvania area, in Southern California, some parts of Texas are tending to have a pretty broad array of at least one plan that offers some of these supplemental benefits. Just moving on along, here, SSBCI meals. So this is a little different than some of what we've been talking about. Plans have been able to, Medicare Advantage plans have been able to provide some limited meal benefits before SSBCI, and those meal benefits were available after discharge from a acute care event, so after discharge from the hospital, or on a limited basis for help in dealing with the condition. Now meals can actually be offered beyond a limited basis. So this meals number here is those meals that are being offered beyond a limited basis. There are more than 71 plans offering meals, and we have that number a little bit later on in the slides, but this is that extended benefit. So that's what you're seeing here with the 12 states and 71 plans. And again, you have these visual representations of where this is being offered, which hopefully will be helpful to you all, so you can see if these are benefits that are available where you live or where you provide services. Pest control. So this is a wholly new benefit that is available, and we're seeing over 1 million Medicare beneficiaries are enrolled in a plan that has pest control as a possible benefit. I'm just going to slide along here. Transportation for non-medical needs. So this is another one I just want to explain in a little more detail. Plans, MA plans, have been able to provide transportation for medical appointments. The expansion here is to be able to provide transportation for things like grocery shopping or other activities. And so we're seeing 88 plans are actually offering non-medical transportation. So new benefit, never available before in Medicare. You'll see many more plans than this offer medical transportation, non-emergency medical transportation. I should clarify that as well. And again, you can see where it's being offered. indoor air quality and equipment, we have 52 plans just in 3 states offering this benefit. And you can see it's a more limited smattering. I think one thing I just want to highlight for folks too is that there are at least a handful of plans that are offering sort of a flexible benefit where they, either the individual selects a benefit out of a menu of options. That's something that Anthem is doing in quite a few of their plans, or where a sort of a care coordinator works in combination with the member to figure out which services most meet their needs. And so, some plans, I think what you're seeing in the data is, and we're still sort of digging into this in the benefit details, but you're seeing some plans that are offering sort of a menu of options. And so they might show up in lots of these maps that I'm showing you because they're offering that menu of options. So there's a plan in South Carolina that you're going to see. You're going to see this area in South Carolina highlighted again in a couple of slides, and that's what's happening there. So a social needs benefit, this is an interesting one, which is maybe a little bit less obvious as to what this is. But this is access to programs that help with social needs, and they could be things like community or social club memberships. We saw actually a plan that allows for members to visit a beauty shop for social interaction to address enrollee isolation. So this is taking a number of different forms, but is an interesting benefit that is pretty innovative, I'd say. And again, you can see where those are being offered. I'm just going to keep flipping through these. There's that county in South Carolina, those counties in South Carolina I was mentioning. Services supporting self-direction is next. I'm just going to move through these quickly because of time, but you know what's in here and you can come back to it. Here you can see structural home modifications only being offered by Geisinger. And then general supports for living, transitional supports. This is where a plan could even pay for some housing expenses. This is only available in 4 states right now. Again, it's a very limited benefit in terms of dollars, but it looks like this, where it is being offered, is really focused on safe transitions from one care setting back to the home. So I saw at least one plan that is offering a limited, very limited assisted living benefit in California under this general supports for living category. Okay, and then this other last item, other SSBCI, this is service dog support. So this is a benefit that Anthem has made available in 51 plans, and that is what other SSBCI is this year. That might look different next year, and that's where that benefit is available. And then this slide here, other popular benefits, this is what I was mentioning earlier. This is transportation for medical services and the limited duration meal benefit. These are very popular benefits, as you can see, that have been available for some time. So those sort of incremental benefits that we were discussing earlier around transportation and meals are in addition to all of these plans offering these benefits. Okay. So trends and challenges. Medicare Advantage enrollment is growing. This is from the Medicare Trustees Report. We expect enrollment to continue to grow. That's what this slide is really showing you. And MA plans are starting to recognize the value of some of these non-medical services in managing health care and reducing unnecessary healthcare costs, unnecessary healthcare services, those those hospital admissions that are avoidable and we all want to avoid. Plans are recognizing the value of things like meals in lowering those unnecessary services. And we are seeing these benefits starting to play a role in meeting individual needs. So a couple of ways that we're seeing that I-SNPs, these are institutionally eligible special needs plans, that the special needs plans are a type of Medicare Advantage plan that is focused on a specific grouping of beneficiaries. These are focused on beneficiaries who need help with activities of daily living, have an institutional level of care need. We're seeing that 85% of these plans are offering a transportation benefit, which we think points to this idea of tailoring these benefits to individual needs, as many of the folks who are enrolled in these plans, truly need transportation in order to be able to get to those services that they need, given their level of functional impairment. Another example that we've listed here is from CareMore, where they offer home-delivered meals, and they have reported some really impressive reductions in readmissions and in even in BMI. And so, these are just some examples of how we're seeing supplemental benefits being used and resulting in improved outcomes and meeting individual needs. Lots of good news here. There are some challenges, and we've listed some of them here. This is new, right? And plans are figuring this out. So are beneficiaries, so are providers, and these are some of the challenges. This is new. Plans have a limited understanding of why would these things be attractive to enrollees. They're going to have a conservative view of benefit design. The funding is limited. Plans want to be able to offer these benefits consistently over time. So I think it's new. There's a bit of a dipping the toe in thing that's going on right now, and so those are some of the challenges. We're also seeing there's not necessarily easy ways to communicate with and aggregate provider networks across the country. You have lots of providers that only offer services in a very limited area, but plans may be looking to offer benefits in a much broader service area. So that is, there definitely are challenges. We can overcome them, but we're learning. And there are also providers that are uncovering issues. So, some consumer confusion around, I have this new benefit in my Medicare Advantage plan, but maybe they've been receiving benefits from a home care provider for years, and how do those things interact? This is the first time that some providers are interacting with the Medicare Advantage system, and IT system issues and lack of information. There's just not, it's not obvious how to do this, how to get signed up to provide services is not something that's intuitive. So a lot of learning that still needs to happen. And as Mary pointed out, we are continuing to work on this and want to be and will be hopefully part of the solution to some of these challenges. And then very importantly, the dollars are limited, and so don't become overwhelmed by this slide. The main thing I want you to take away from it is that Medicare Advantage plans can only really spend a small increment of their total funding from Medicare on these benefits. They can spend what's called the rebate dollars, and that average rebate is around $100 a month per member. And that around $100 per month is going to be what is spent on all supplemental benefits. So that includes hearing and vision and dental, in addition to the things we're talking about right now, and also to reduce out-of-pocket spending for their members. So it's limited dollars, and there's competition for those dollars. And so, that's very important context for all of this. Moving forward, we really do need more evidence and more evaluation and more testing to really show how these benefits can be used to meet the individualized need of Medicare Advantage beneficiaries, and also to do what we were talking about earlier in reducing those unnecessary healthcare costs. So I want to give us all time now to answer some questions. I think one thing that I will leave up and leave us all with is this vision for what does care look like for these complex care populations. We really see the plan entity as being important in that it holds risk, and that aligns the financial incentives to maximize control and deliver this flexible and individualized care. And we see tech enabling some scale and risk management. We think primary care and communication is really important. And we think that highly targeted and personalized medical and non-medical interventions, even though we don't have the Medicaid dollar, are going to be really important to managing the care for this population. So with that, I will turn it to Steve, I think, for questions and discussion.
Okay, great. Thank you very much, Mary and Tyler. The first question here, and yes, it is time for a Q&A, everyone, so send in your questions using the questions box. First question for you. Where can you get a list of benefits and what plans are offering each benefit in the state you live in?
So this is Tyler. There is not there's not a very easy answer to that. So CMS, the Centers for Medicare and Medicaid Services, publishes some data files called the Plan Benefit Package files, and that's where we were able to pull the information that you see in the slides. We were able to analyze that data. But there is not, there's not like an easy place where you could go and say, like, show me all FSBCI in Florida. There is some information on Plan Finder, and then getting benefit details actually is you have to go into the EOC documents of the individual plans to get the benefit details. So if there's a specific question someone has, I'd be happy to look at it and see what we might be able to provide you from the analysis we've already done. But there's not a simple one-stop shop to just see all the plans and what they're offering. But that sort of information is something that we're working on and think is important for transparency, going back to the guiding principles that we highlighted earlier.
Okay, next question. If I have an expertise in one of the new potential services, how do I best approach the managed care providers in my area to share data and discuss opportunities?
So, and Tyler, you might have thoughts on this, but this is Mary. I'll just chime in here that one, I think, the first step is just doing a brief environmental scan, find out who the Medicare Advantage plans are in your area. And I think go to them with data in hand, right? So if you're already providing some of these benefits through your, I don't know if this is coming, I'm assuming from an organization or an agency, and how many Medicare beneficiaries you're already serving, what you've seen with the populations that you've already been providing this to, how you are providing this benefit, what your recommendations are for how you would communicate with them, what kind of quality assurance and protocols and processes and quality improvement processes do you already have in place. I think the Aging and Disability Business Institute has a lot of really great resources on developing your value proposition and kind of making that elevator pitch. So I would really encourage you to check out some of the resources that the Business Institute has, because you really just have to develop that value proposition and start having that conversation with the Medicare Advantage plans. I think really tying it to their beneficiaries and how, and even if you don't have hard data on cost savings or improved outcomes, do you have any data available on member satisfaction? and how you can help improve the satisfaction of their members if you were to partner with them for some of these services. Tyler, I'm not sure if you have anything additional to add there.
I think that was great. I think that's right on, Mary.
Okay, next question. I'm afraid we'll have many seniors that qualify for services that won't know how to use them, and also afraid that we have seniors signing up expecting these services and their plan will not cover it. How transparent do the Advantage plans have to be to these seniors?
This is Tyler. I think that is a really good question. You know, you're right to highlight the fact, and as we've highlighted throughout the presentation, that just because a plan is offering a benefit does not mean that someone who's enrolled in that plan is eligible for the benefit. So, you know, that is, you know, one of the guiding principles is that, you know, the benefits are clear and understandable, and I think that there are some challenges here in communicating that. So I think there is a role, of course, for the plans who their EOC documents should be very clear as to what is covered. But a lot of times, I think, you know, you're not going to know for sure that you're eligible for a benefit until you're enrolled in the plan. So, you know, very much understand the question and the concern. And I think that this is something we need to be very thoughtful about, you know, both providers, beneficiary advocates, AAAs, you know, the whole group, you know, everyone that communicates with beneficiaries. I think we really do need to be clear about what these benefits are and what they aren't. You know, there's a lot of potential here, and, you know, as we've highlighted, this is truly the first time in Medicare that many of these services can be covered at all, and so, you know, that's forward progress. But the communication around these plans, that they're clear and understandable, that you know, the other thing that can happen is a benefit may be offered in one year and it may not be able to be offered in another year because of the limited resources associated with this. So I don't know that I have 100% answer for you, except to say that we know that this is an issue. This is something that that we're focused on, that others are focusing on, and that, you know, just really clear communication and education is vital and needs to be ongoing.
Yeah, and I think the only, you know, small thing that I would add here is that I think Medicare Advantage plans are definitely acutely aware of this, and it is one of their considerations in offering these benefits is how they can communicate it, and not wanting to make it seem like everyone's available and then having a lot of really unhappy members. That does not lead to good, you know, member satisfaction and retainment, which they want to be able to do. And so, you know, there is no silver bullet, I think, fix-all solution for this. But of the plans that we worked with as part of the working group and the health plan associations, this is something that they are very aware of. And I think plays a role in how many plans we see dipping their toe into this water, because they want to make sure that they're able to appropriately communicate this and that they're reducing confusion wherever possible, because it can get really confusing for beneficiaries.
Okay. Well, Tyler and Mary, we have unfortunately reached the end of our hour and we are out of time, but I want to thank you for a great presentation today and for joining us. Thank you so much.
Thank you.
Thanks. Thank you so much.